Welcome to another PrecisCa tumor board. We've got several cases to discuss today, very good cases with some challenging questions and some interesting decision-making pivot points throughout the care of the patients presented here. I just want to start with some introductions before we get started. I'm Dr. Benjamin Levy, and I'm associate professor at Johns Hopkins School of Medicine. I'm a lung cancer specialist and also the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. We'll just briefly go around and I'll allow each of you to introduce yourself. So I'll start with Dr. Keston.
Yes, I'm Larry Keston. I'm a radiation oncologist. I'm a clinical professor at Wayne State University in Michigan. I work for Genesis Care, and I am the medical director of radiation oncology in the Michigan region. I also am the director of, I'm the chair of thoracic radiation oncology for the American Board of Radiology.
Hi, I'm Dr. Jack West. I'm a medical oncologist focused on thoracic oncology. I work as an associate professor at the City of Hope Comprehensive Cancer Center in the Los Angeles area. Happy to be here.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Radiology at Memorial Sloan Kettering Cancer Center. And I'm also a professor of radiology at Weill Cornell Medical College and a vice chair for education at Memorial Sloan Kettering Cancer Center in radiology.
Hello, I'm Dr. Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of Thoracic Surgery at Emory University Hospital in Atlanta, Georgia.
This is a stage 4 adenocarcinoma with an EGFR mutation. It's a 73-year-old male, never smoker with stage 4 EGFR mutant lung cancer, currently on osimertinib. Now with evidence of progression on PET-CT, what would be the treatment that would be recommended? So the patient initially presented with decreased exercise tolerance. The performance status is 1. The medical history is only consistent with GERD and high blood pressure. He's a never smoker and no alcohol or illicit drug use. And the family history is consistent with a father with prostate cancer. The first imaging we have is in December 2020, a chest x-ray with a right lung mass and a right pleural effusion. He ends up getting 1 month later a thoracentesis that removes 1.5 liters. The pleural fluid cytology is adenocarcinoma, it's TTF1 positive. The Garden 360 is negative. We can talk about the sensitivity of a Garden in this setting. The MRI of the brain is negative for metastatic disease. Patient has a PET scan that reveals a large right pleural effusion with a 3.4 by 2.6 central right perihilar mass with some mediastinal adenopathy, no evidence of metastatic disease. He, I think importantly, does get a bronchoscopy with another thoracentesis to remove fluid from the right lung. The Caris testing, I assume from either the thoracentesis, maybe there was a biopsy done, is positive for EGFR mutation. We're not sure what type here. We can talk about that too. And the patient is initiated on osimertinib, which I think we can argue for the sensitizing mutations in EGFR 19 and 21 is a standard of care. 8 months later, the patient has a CT chest with concerns of possible progression. The PET scan shows progression in the right hilum, right pleura, and the L5 vertebral body. And so, Dr. Ginsberg, you want to walk us through this PET from January 2021, please?
So this is the initial PET from January 2021, which demonstrates this large pleural effusion. And the arrow is pointing to that hilar mass, which is FDG avid, and on CT measured up to 3.4 centimeters in size. There was also some mediastinal adenopathy, but it's not depicted on these two images.
And then the PET from October 2021.
So this PET is about 9 months later and showed some progression. Not all of the images are displayed, which would demonstrate that, but we do see that there is a right hilar mass, which is FDG avid. It's in the bottom right-hand corner, and small right effusion with some pleural thickening. So there was progression in the pleura and the right hilum, and also in the L5 vertebral body, but it's not depicted on these images.
Okay. So maybe I'll start with Dr. Keston before we talk about systemic options. So I'm going to go back to at least the read on the PET. I just want to make sure. So the PET scan shows progression of the right hilum, pleura, and the L5 vertebral body, as Dr. Ginsburg went over. Is there a role for radiation for this patient? For, even though there are several sites of disease growth, would you ever consider radiating these areas, Dr. Keston?
Certainly, you can consider radiation treatment for these patients. I think in this particular instance, this is still a bit of a systemic process, and I would like to see, a reasonable time interval without disease progression. But so I personally would think it might be more reasonable to start with another systemic therapy agent, but it would be very interested to see, what the medical oncologist felt. If it's only this particular right hilar location, L5, and a targetable location in the pleura, that would be 3 spots, which would qualify as oligometastatic disease, or in this case, it would actually be oligoprogression, right? Because he's had more widely, metastatic disease. Then one could consider, more definitive radiation treatment to those 3 locations. Hopefully the pleural involvement in that situation would be something that could be targeted rather than, if it's a more diffuse pleural involvement, that's not something that you can really treat with radiation therapy.
Great. And thank you for kind of highlighting the difference between metastatic disease, oligoprogression. I think those are important to discuss. All right, Dr. West, you're on again. We encounter this all the time in our clinic. The patient did not have as good a run with osimertinib as we would have liked. We have a CARES report showing, I assume, an exon 19 or 21 EGFR and was on appropriately osimertinib and now has disease progression. And we can talk about how progression is heterogeneous and we have to define when there's truly a need for a therapeutic switch. But let's say patients in need of a therapeutic switch, what would you do here?
Well, I would just take a moment to highlight, there's that progression is not binary. You've alluded to that, and so did Dr. Keston. And I think it's really important, if this patient had gone 24 months and then had one new lesion, I think many of us would be exceptionally eager to just do SBRT to that spot and continue the osimertinib and be very hopeful that that he would continue to do well for a long period. And there's mounting data to support that that inclination that we have had based on just our guiding principles of the biology. And so, but I think there's a distinction between clinically significant and not significant. When you get a report that says a lesion has grown by 1 millimeter or 2, we don't throw out the baby with the bathwater. And then, is it unifocal or multifocal? In both of these cases, the relatively short disease-free interval, duration of response, and the multifocality of it would lead me to favor a systemic approach. I would love to know more to better characterize the exact mutation here, but I think it is time to look at a new systemic therapy. If there's a clinical trial at your center or within striking distance, there are some really provocative therapies, and I would consider, for instance, at ASCO 2021, we saw encouraging data with the combination of amivantamab, which is a commercially available fully human bispecific antibody against EGFR and MET, combined with, in this case, lazertinib, which is an oral 3rd generation EGFR TKI. There's some trials with combinations like this. There's also an anti-HER3 antibody drug conjugate called patritumab deruxtecan that has, both of these approaches have response rates in previously treated patients after drugs like osimertinib in the approaching 40% range. So quite encouraging, and I would say an option to consider if it's available. Otherwise, I think that we're looking at chemotherapy-based doublets as a cornerstone, and the debatable place is, do you add immunotherapy to that? And you can, but we just don't have good data to say whether immunotherapy adds much to what the chemo is doing. Maybe a role for including anti-VEGF therapy like bevacizumab, but we have really scant data to guide us here. I think it's more judgment than hard data to answer. We will have more in the coming year or two, but that's cold comfort when you have a patient in the clinic now. I'm actually shaped by, some of my own recent and ongoing experiences, which has been rather disappointing with the immunotherapy. So that issue, combined with the concern that if you give immunotherapy, it's complicated and potentially dangerous to go back to an EGFR inhibitor. For instance, if there's brain and progression or something like that, and you really want to control the CNS, it's a potentially quite toxic combination to have immunotherapy in the bloodstream given 3 weeks ago, and then want to start osimertinib. You can get life-threatening pneumonitis. So I would be more inclined to favor chemo, such as carboplatin, and leave the door open to maybe adding back the EGFR TKI and reserve the question of the immunotherapy. But I don't think any of us can be dogmatic about what's the best way. We await prospective data to tell us. I don't know if you have a different perspective here.
No, I think it's a great summary. I think I love your first point, which was made appropriately first. It's a call for clinical trials. I think that would be the first recommendation to find one, given the data sets that you talked about with amivantamab plus lazertinib and the patritumab deruxtecan that we saw. A couple of questions. Do you get both a liquid biopsy and tissue biopsy at the time of this, at this pivot point? Do you do it at all? Do you only do it as a clinical trial? And then I have a second question that's more clinically relevant, but I'll let you ask something first.
Well, I would say that I'd underscore that we don't have enough evidence to say it should be a standard of care just yet, but if it's obtainable, I'd prefer to have it. That there are sometimes, I saw a recent case of somebody who actually had an uncommon EGFR mutation, and then on rebiopsy had a KRAS mutation, but did not have the EGFR mutation and responds now to sotorasib. So there's nothing that you can hang your hat on in terms of prospective data yet, but our anecdotal experiences are enough to potentially guide us. I find myself always thinking of, in the land of the blind, the one-eyed man is king. And so, you do the best you can in these unusual cases. If there is accessible tissue, I would love to get it. If you're talking about small volume chest-only disease, the yield is just not going to be that high yet for a liquid biopsy. So, but if someone's got, a bunch of new liver metastases, it's nothing to cheer about, but at least the yield would be higher for a liquid biopsy to get an answer. So I'd prefer to try to cover that base if I could.
One last question, then we'll move on. I think you alluded to it, and this is one of the most contentious topics in our group. Do you continue the osimertinib or not when you start chemotherapy, or do you save it for rechallenging efforts?
Oh yeah, that's easy. I don't know. I mean, it is a really controversial question. I'll say that, some of the most promising studies that we're looking at in the first line setting are combining chemo and EGFR TKI, like the FLAURA2 trial. I strongly suspect that in 3 years, we're going to be doing that. And I think the data have looked very good. I would not have any reluctance to do that in somebody who had brain metastases and responded or had some progression in the brain as one of their sites of progression. So I don't do it for everybody, but I would have no hesitation to do it, for at least selected patients. And even if I'm not, as in this case, I think I wouldn't be that inclined to do it in someone who had a rather underwhelming response in the first line. I'm not that impressed with what osimertinib's done for him so far. And because of that, I would probably put it on the side. But again, I'm not committing against doing it in the future, resuming it. And you might get at least a short-lived response after some EGFR TKI free interval.
Great point. So we'll summarize this case. We have one more case after this one. So number one, potentially another reinterrogation of the tumor via either tissue biopsy or liquid biopsy if there's a clinical trial available. Two is carboplatin pemetrexed-based regimen with, at this point, not as much enthusiasm with immunotherapy as we are in other settings. So carboplatin pemetrexed. It may be also a consideration of osimertinib if there were brain mets, but maybe not, just depending on the clinical scenario. I hope I got that all. Is that an accurate summary?
I think so, yeah, of an admittedly ambiguous situation too.
Yes, I agree. We are in the data-free zone. Hopefully, like you said, hopefully we'll have some answers here, at least with the immunotherapy with Keynote 789, whether that adding immunotherapy will make a difference.